Guys, this Wednesday's teaching is kindly delivered by Kashif. He is a specialty doctor from Firmly, and he is going to tell us about lunate instability and associated disorders and injuries. And this is no doubt a high yield topic in the FRCS exam. So please, I'm sure this is going to be a fantastic presentation. So please listen carefully, and we will discuss some of these issues also in more depth in the hot seat session. So please pay attention to Kashif. Go ahead, Kashif, please.
Okay, good guys. Thank you for listening. So I'm going to present a little bit about lunate and perilunate dislocations. If you have any questions, please just write down and ask at the end. So anatomy of the corpus. Corpus is divided. Carpal bones are divided into the proximal and distal carpal rows, and each row has 4 bones. You already know that. So the on this diagram, this pink line shows greater arc, and then blue and red line show the lesser arc, because these injuries are divided according to these arcs. You already know about the ligaments around the corpus, which is divided in intraosseous ligaments, which runs between the carpal bones, and they are major stabilizers of the proximal carpal row. And then intrinsic ligaments, which is divided into dorsal and volar, and then extrinsic ligaments, which connects the forearm bones to the carpus bones, which is again divided into volar and dorsal. You already know the anatomy of the corpus. Sure. So the types of these dislocations, they are divided into perilunate dislocation, where lunate stay in the position while carpus dislocates, and lunate dislocation, where lunate is forced out of the corpus, either volar or dorsal. Volar is the most common. So the mechanism is usually traumatic, high energy type of the trauma. It occurs when a patient falls on wrist with extension and ulnar deviation that leads into the intercarpal supination. The injuries are divided, as I told you earlier, into the greater arc injuries, which is represented by the blue line here, which involve the fractures, and a lesser arc, which is purely ligamentous injury, which is shown by the red line. The sequence of events in this injury, which starts from the scapholunate ligament disruption, and then followed by the disruption of the capitolunate articulation. Subsequently, there is a disruption of lunotracheal articulation, and then that is followed by failure of the dorsal radiocarpal ligament that leads to lunate to rotate and dislocate, usually into the carpal tunnel, which is volar. So you don't need to remember the classification, but for the purpose of completion, so it is divided into 4 stages. Stage 1, when there is a scapholunate dissociation. Stage 2, scapholunate dissociation plus lunocapitate disruption. And then stage 3 is a scapholunate dissociation plus lunocapitate disruption, and plus lunotracheal disruption, that is mentioned as perilunate dislocation. And stage 4, where lunate is completely dislocated from the lunate fossa, usually in the carpal, usually on the volar side. And the stage 4 is usually associated with median nerve compression. Patient usually, as I mentioned earlier, high energy trauma, patient present with acute wrist swelling and pain. Median nerve symptoms is mentioned in the literature in around 25% of the patients, usually in Mayfield stage 4. So from the radiology point of view, you will go for AP and lateral radiograph. In the AP radiograph, you can see there is a break in the glula arc, and there is a and usually there is a lunate and capitate will overlap, and you can see sometimes lunate appears triangular as in the second radiograph, which is called piece of the pie sign. And on the lateral radiograph, you usually see there is a loss of collinearity of the radius, lunate, and capitate. In normal radiograph, you see then all three bones, they are aligned in one line. But in this type of injury, you will see there is a disruption of this collinearity. So management is divided into the according to the acute, whether this is acute injury which is less than 8 weeks, whether this is chronic injury which is more than 8 weeks, and whether this is chronic injury with degenerative changes. So management is divided into 3 different categories. In acute injuries, usually management is emergent close reduction followed by splinting, and subsequently there will be open reduction with ligament repair, and then fixation if there is any fractures, and a carpal tunnel release, usually done by the hand surgeon. So for the emergency, you need to just do the close reduction possible, followed by splinting. If you can't do the close reduction, then you have to get advice from your hand surgeon. But then a patient need a open reduction and carpal tunnel release. Then second stage will be open reduction along with a ligament repair with fixation. So then dilemma is whether you need to go for volar approach or dorsal approach. If there is carpal, if there is median nerve compression, then you will go for volar approach. If there is no median nerve symptoms, then most of hand surgeons, they will prefer dorsal approach. But again, it depends on the surgeon choice. And then in second stage, while you are doing, so you need to fix the associated fractures. Then you need to repair the scaphoulnar ligament, usually with the suture anchor fixation. And then you have to protect your ligamentous repair with a temporary fixation. Most of time they use a temporary KYS, which need to be taken out in around 4 weeks time. And then a repair of the lunotracheal ligament, that again depends on the surgeon choice. Some hand surgeons go for repair of the lunotracheal ligament, some surgeons don't. And as I mentioned in my earlier slide, in chronic injuries, which is more than 8 weeks, so options is proximal row corpectomy, while chronic injuries with degenerative changes, option is wrist orthodesis. Then post-operative management for the this type of injuries, usually post-operatively, patient will be in the thumb spica splint from theaters, and subsequently patient will be coming back to wound management clinic, where there will be a hand therapist which usually apply the thermoplastic splint, which is usually bellow elbow type of the splint. And duration of the splinting varies, but usually between 4 to 6 weeks is sufficient for these type of injuries. Usually this patient has, if this injury is managed appropriately, usually patient has good outcomes, but most of time these are quite missed injuries. So you need to be you should have very high suspicion of index with these type of injuries, because sometimes X-rays are deceiving and you may require further imaging. So guys, any questions? This is just brief overview. I haven't gone too much details. I don't think you need a detail more than this presentation for your exams.
There's one question, Kashif, which I think you already answered.
Yeah.
Is what do you do if there is a closed lunate dislocation?
Yeah.
Patient comes in the evening.
Yeah.
And showing signs of median nerve compression. And I think you already answered that in your, but I don't know if you want to add anything to it.
Yes. So answer to your question, if patient is coming in the evening with a closed injury, but with median nerve symptoms, so the options are, you need to try close reduction once in the A&E. So you will give traction, counter traction with a hand in the dorsiflexion, and then you will push the lunate into the fossa and bring the hand into the palmar flexion. So if there are median nerve symptoms already, so you don't need to push too hard and no second attempt in the A&E. Then you need to prepare this patient for theaters for open reduction along with the carpal tunnel release. In the meantime, you have to discuss with your hand surgeon or upper limb colleague, because some hand surgeon, what they want just carpal tunnel release and relocation of the lunate, no wires. Some hand surgeons are quite happy to put the wires for temporary stabilization, and then patient will go for second stage repair of the ligaments if needed.
Do you think, Kashif, as for the exam purposes, as a general orthopedic surgeon and trauma approach, do you think we should be talking about ligament reconstruction, or should we keep it safe and just say?
So I think you need to keep it simple.
Yeah.
So you need to just deal with the emergency, which is your median nerve symptoms.
Yeah.
So I'm sure everyone knows how to release the carpal tunnel. So you will go for extended carpal tunnel approach. Once you have retracted the structures, you will see the lunate will be lying over there. So you need to just push the lunate back, and that's it.
Yeah.
And then you will close the wound. And as I mentioned earlier, temporary stabilization with wires or no wires, that depends on your hand surgery colleague. If they like wires, then you put a couple of wires to hold the bones together and close the wound, and then splint. If they don't like wires, then once it is reduced, and it is quite stable then.
Thank you, Kashif. I think Athar has joined now. Welcome, Athar. And he has a question to you.
So, Kashif bhai, I have been told on various occasions that there is a very valid role of Chinese finger trap. And this is a repeated scenario can be in any exam setting, in terms of where you say, oh, patient just had a burger, or patient just had a Lucozade bottle. What will you do? Patient is developing median nerve symptoms, and the answer is that. What are your thoughts about it?
Yes, you're right. If patient has median nerve symptoms, and if patient has like as you mentioned, Lucozade or burger or whatever, the patient can be put in the Chinese trap with around 2 to 3 pounds weight on the opposite side. So you need to put a Chinese trap, and with a pulley system, you will put a 2 to 3 pounds weight, and with the weight of the arm, usually it reduces. But to be honest with you, I have not seen personally myself. Yeah. While I was working in my hand unit, so I have done 3 in the evening, and fortunately, all 3 patients was nil baba.
Sure.
Okay.
What do you think? What do you think?
I think you're asking for trouble here if you, in the exam, if you suggest you're going to put a patient who's developing median nerve symptoms on finger traction. You can do it temporarily while you're waiting to go to theatre, but patients who are, even if they've got a full stomach, you can do rapid sequence induction patients, and it's a limb-saving emergency, so therefore you are justified to go ahead and do this.
Exactly, yeah. I agree with Shwan. I think for the exam purposes, this is the limb threat. If a patient started to develop median nerve symptoms, this is becoming limb threatening, and then for rapid sequence discussion with anesthetist, it's a limb threatening situation.
Absolutely.
Because it might not be just a median nerve. He might be developing compartment syndrome.
Absolutely. So there are 3 different scenarios in this situation.
Yeah.
So if your theaters is busy, for example, laparotomy is going on or whatever, so you need to open second theater. This should be answer. You need to open the second theater, and you need to bring the second team to do the decompression.
Yeah. I think make it clear to the examiner, I want to operate on this patient straight away. he keep asking you this and that. The patient
Yeah, absolutely.
food, a patient, I don't know, not ready, theater busy. As far as you're concerned, you're concerned for the safety of the patient, of the viability of his limb. Any further comments, Shwan?
There is one other scenario where you have a patient who is unable to go to theatre for whatever reason, stuck in ICU, intubated, for other injuries, but you've got the X-ray confirming a lunate dislocation. If you leave this patient for 24 hours, they will have median nerve symptoms. So your options, and this was going to be a hot seat question for me, but since we brought this up, we might as well talk about it. You can do a carpal tunnel release while the patient's in ICU or even on the ward. It's the safest thing to do for this patient, and that's how you would argue. You would be reluctant to do it in any other situation, but in a last resort, you can do a carpal tunnel release while you're waiting to get the patient into theatre, while the patient's fit for later on.
Was one more question, Kashif.
Yeah.
Is the AVN a common problem with lunate dislocation as a complication of the injury?
It's a complication. It is a problem because if you have lunate dislocation, blood supply is disrupted. It is a problem. I'm not sure how much is the percentage. Sorry, I don't know what is the exact percentage.
I think we might never know the exact, because not all AVN is symptomatic, and therefore we might not know down the line, years down the line, patients could be at discharge. So we don't know exactly, but I think for example, I would say it's a recognized complication, long-term or short-term complication. But
absolutely, yeah.
Juan, do you know anything more about this? No, but
because
I'm sure
doesn't mention how much exact percentage is there.
I'm sure there's somebody that's written a paper on it, but to be honest with you, it's irrelevant to managing the patient in an emergency situation. If you're down to discussing AVN rates, you're quoting papers at that stage. So it's unlikely you're ever going to reach that in an emergency discussion of this situation. More important is that you've saved this patient's limb.
Any further comment, Athar, about this topic?
No, I think the scenarios, the three scenarios that is being covered, is covered. But I've been told by the examiners about the Chinese strap scenario as well. But you are
absolutely right. But sometimes if you haven't seen anything, because what they want what you are going to do.
Yes, exactly. So the safe answer is as you guys have suggested. Yes. And that's what you're going to do, and you're going to stick to your guns, irrespective of whatever you.
Yeah, I think overall, my general advice is for this FRCS exam, number one priority always in any questions you ask is safety.
Absolutely.
Safety. Okay. That's more important than any fancy treatments that you might know about.
Yeah, exactly.
Yeah.
Which could look very impressive. I know a lot of it. Sometimes just simple things, sticking to your guns, is what will get you through the exam. Just review it again. You won't need. I don't think you need anything more to pass.
No.
Just need to know the principles, the anatomy. And we will recap a little bit more on this during the hot seat session.
Absolutely.
With this topic and any relevant topics. I mean, obviously, some guys want to know about Visi and Dizzy.
I think. Should I discuss this in the hot seat with the Visi and Dizzy?
Yeah.
Good. I think that's a good idea. Good idea. Okay, so. That was a very good, Kashif. Again, another very good presentation from you. We had 36 people attended today, and we will collect feedback, but that was very good. As I said, there is hot seat session will follow in 2 minutes.
Okay.
So we got Athar, Shwan, Kashif, and myself will be here. asking you questions, guys. So please, as soon as you re-log in,